Hi, my name is Faiza Ahmed, and I am an internal medicine resident at DMC Sinai Grace Hospital. My case today addresses the routine use of Bactrim for the treatment of urinary tract infections in the outpatient setting. Systemic lupus erythematosus is an autoimmune condition that is well known to be the great Systemic lupus erythematosus is an autoimmune condition that is well known to be the great mimicker of modern times. One of the more severe and disease-altering associations for SLE is the kidney damage that comes along with it. There are various types of kidney damage associated with lupus based off of histopathology, but all of them lead to impaired renal function due to immune-mediated damage to the renal architecture. Lupus nephritis itself is independently associated with end-stage renal disease and increased mortality. Flares of lupus with renal involvement increase the chances of progression to further kidney damage and ending up with dialysis dependence. This case is of one such patient, an 18-year-old female with known history of SLE and biopsy-diagnosed Class 3 and Class 5 lupus nephritis who presented to the emergency department with complaints of increased urinary frequency and a urinalysis suspicion for an infection with elevated urinary white cell count and 4+ bacteriuria. She was stabilized in the ED and prescribed a 5-day course of Trimethoprim-Sulfamethoxazole, commonly known as Bactrim. Within 4 days, she came back to the ED with complaints of pleuritic chest pain, photophobia, shortness of breath, diarrhea, and pain in her back, bilateral elbows, bilateral wrists, and left ankle. Initial vitals showed a blood pressure of 90/56 millimeters of mercury, heart rate of 118 beats per minute, respiratory rate of 24 breaths per minute, temperature of 38.6 degrees centigrade, and saturation of 98% on room air. Her lab values were significant for an elevation in creatinine of greater than 0.3 grams per deciliter, indicating an acute kidney injury, a small decrease in hemoglobin along with schistocytes on peripheral smear. Her urinalysis, however, showed a decrease in white cell count as well as a decrease in bacteria, indicating some amount of response to the treatment. She continued to have high levels of proteinuria, along with hyaline Cas in the urine. Her C3 was 56 and C4 was 9, indicating that some consumption was ongoing, along with an elevated ANA titer at 1:1280. She was initially given steroids and IV fluids, which helped to resolve her symptoms, and restarted on the hydroxychloroquine and mycophenolate mofetil that she was supposed to be on. However, within the next 5 months, she had another 3 hospitalizations with similar complaints, with the result that she became dialysis dependent at the end of this time. Sulfa drugs are a common source of drug allergies. Bactrim itself is generally well tolerated and an effective medication for urinary tract infections, especially in the general population. Certain groups, however, warrant greater caution. Each SLE flare worsens the disease prognosis and hastens the journey towards end-stage organ damage. In patients such as this one, already on the road to ruin with non-compliance to essential treatment, it becomes even more important to follow the Hippocratic principle of do no harm. Each successfully prevented flare is an unrecognized victory in this disease. Bactrim, unfortunately, served to push this patient further along the road to becoming dialysis dependent at the tender age of 18 years.